behalf of myself, Juan Terry and Isaac George, it's a pleasure to present over 15 years the advancement of transcatheter aortic valve replacement. By way of background, it's well established that the prevalence of heart valve disease is strongly age-related, and aortic valve disease is no different, and in the over 75 age group, the prevalence in the community approaches 4 to 6%. In combination with an aging population, this has presented an epidemic of heart valve disease and a requirement for therapies. The first aortic valve replacement was performed surgically in 1961, and it was really the invention of the heart-lung machine, first used in 1953, which permitted this landmark development. The first steps towards transcatheter management of aortic valve disease were performed in 1985 with the first balloon aortic valvuloplasty, and this first-in-man procedure demonstrated that inflation of a balloon within the aortic valve is feasible. This can generate an immediate improvement in hemodynamics and patient symptoms, and there was considerable expansion in the use of balloon aortic valvuloplasty up until the 1990s. It remains in use 30 years later in specific subsets of patients, and technical improvements led to dramatic increases in the safety of the procedure. However, there were a number of issues with BAV, such as the lack of consensus on the techniques and goals, early restenosis of valve disease up to 80% at a year, and there was no effect on mortality, and as such it was abandoned in most centres, really from the mid-90s. However, there's been some resurgence in its use as a bridge to destination therapy with TAVR. The eureka moment for TAVR came in 1989, with Henning Rudd Andersen, a Danish cardiologist, experimenting in pigs, and recognized that in the same way as stents, it might be possible to create a balloon expandable valve crimped onto a metallic frame, which could then be delivered via transcatheter approach and then expanded on a balloon in situ in the aorta. This work was developed and subsequently published, but not without considerable difficulty. And it was not until 2002 that the first-in-man procedure was performed by Professor Alain Cribier in Rouen. This first procedure in a human subject taught the community a number of lessons: the feasibility of TAVR, the possibility of accurate valve placement with no valve embolization, a successful deployment without coronary occlusion or impingement on the mitral valve, and that there was no AV heart block. The patient had only mild paravalvular regurgitation and optimal transcatheter heart valve function with good hemodynamics. This first procedure lit the touch paper for the subsequent few years, known as the transeptal era, the first 40 patients, and the initial iRevive and RECAST trials. These procedures were performed for compassionate use for patients facing imminent death. Approximately 85% were successful technically, and a number of patients survived greater than 5 years. And TAVR took its first flights abroad towards the first 100 cases. The takeover of percutaneous valve technologies by Edwards Life Sciences in 2004 began the transition of TAVR into both a mainstream clinical and commercial reality. The early Cribier-Edwards 23mm valve was redesigned and accompanied by delivery catheters for implantation of the valve from the retrograde transfemoral and antegrade transapical routes, opening the door for widespread adoption of the procedure. The partner series of randomized controlled trials have become the foundation of the evidence base supporting TAVR. Partner B demonstrated the survival benefit of TAVR with the balloon expandable sapien valve over medical therapy in patients at prohibitive risk for SAVR, with a hazard ratio of 0.51 for death over 24 months, one of the most impactful treatments seen in a contemporary randomized trial. Partner A, evaluating TAVR against SAVR in patients at high surgical risk, demonstrated non-inferiority for TAVR for the composite primary endpoint of all-cause mortality or major stroke. In the core valve US pivotal studies, the self-expanding core valve device was associated with a significant reduction in all-cause mortality and stroke at 1 year against an objective performance goal in patients at prohibitive surgical risk, and a significant reduction in mortality for patients at high surgical risk. These landmark studies drove a 1A recommendation in the 2017 ACC STS guidelines for TAVR for symptomatic patients with severe AS at prohibitive risk for SAVR, and the inclusion of TAVR as an alternative for those at high risk. 2 subsequent randomized trials evaluated the role of TAVR in patients at intermediate surgical risk, Partner 2A and CITAVI. Partner 2A randomized 2,032 patients with an STS risk of 4 to 10% to TAVR with the SAPIEN XT valve or SAVR. At 2 years, there was no significant difference in the primary endpoint, a composite of all-cause mortality or disabling stroke. CITAVI enrolled 1,746 intermediate risk patients with an estimated surgical mortality of 3 to 15%, with randomization to TAVR using the self-expandable core valve system, or SAVR. CITAVI also found no significant difference in the primary endpoint, the composite of death from any cause or disabling stroke, between TAVR and SAVR at a follow-up of 2 years. Based on the non-inferiority of TAVR in these key trials, both European guidelines and US guidelines granted TAVR a recommendation for use in intermediate risk patients subject to a heart team evaluation of patient risk and anatomical profiles. Following on from the high and intermediate risk studies, Partner 3 and Evolute low risk evaluated TAVR against SAVR in patients at low surgical risk. This group accounts for approximately 80% of the patients undergoing SAVR. In Partner 3, 1,182 patients with an STS score of less than 4% suitable for transfemoral TAVR were randomized to TAVR or SAVR. Importantly, the primary endpoint for Partner 3, in contrast to Partner 1 and 2 studies, was the composite of all-cause mortality, all stroke, or cardiovascular rehospitalization. At 1 year, the incidence of the primary endpoint of all-cause mortality, all stroke, or cardiovascular rehospitalization was 15.1% for SAVR versus 8.5% for TAVR, giving a hazard ratio of 0.54. For the key endpoint of death or disabling stroke, the incidence was significantly lower for TAVR compared with SAVR, 2.9% versus 1%, giving a hazard ratio of 0.34 for TAVR. Amongst the secondary endpoints, there were some points to highlight. TAVR was associated with a significantly lower risk of life-threatening or major bleeding, but a significantly higher risk of new-onset left bundle branch block, although for the first time in a TAVR versus SAVR study, no significant difference in the rate of permanent pacemaker implantation. The Evolute low-risk study used a Bayesian adaptive study design to evaluate TAVR with the self-expandable Evolute valve in 1,468 patients who were randomized to TAVR or SAVR. The primary endpoint of the study was the composite of all-cause mortality or stroke at 2 years. Over the first 12 months, as shown here, and indeed out to 24 months, there was no significant difference in this composite endpoint, which was technically significant for non-inferiority between the two approaches. In summary, Partner 3 and Evolute low risk demonstrated that transfemoral TAVR offers at least equivalence to SAVR in selected low-risk patients over a short follow-up period of 1 to 2 years, completing the evidence across all risk categories. An updated meta-analysis of all randomized studies of TAVR against SAVR across the spectrum of risk demonstrated that TAVR is associated with a reduced risk of mortality with a 12% relative risk reduction. This risk reduction is even greater for transfemoral TAVR, approaching 17%. Looking across the subgroups, there was no heterogeneity in signals seen in the different risk groups, suggesting a consistent benefit across the spectrum of risk. Of note, transthoracic access was the only group where TAVI was inferior to SAVR. In this study, the risk of stroke, major bleeding, new onset atrial fibrillation and acute kidney injury was also lower with TAVR than SAVR, but the risk of permanent pacemaker implantation was higher. However, it's important to note that low-risk patients with unfavourable anatomy, for example bicuspid valves, extensive LVOT calcification, poor transfemoral access, were excluded from the low-risk TAVR population. In addition, the risk of PVL remains higher with TAVR and the durability of transcatheter heart valves remains uncertain. These issues represent significant ongoing challenges before TAVR is ready for widespread use in the low-risk population. Since the first TAVR, there have been huge engineering advances in both the design of transcatheter heart valves and the delivery system. The size of the access sheath required has decreased dramatically from a 22 to 24 French sheath for the original SAPIEN valve down to a 14 to 16 French sheath for the SAPIEN 3 and a 14 to 18 for the Evolut Pro Plus. In turn, this has significantly reduced the number of vascular complications associated with the procedure and increased the proportion of cases which can be carried out from the transfemoral route. Valve design has been sequentially iterated over 3 generations of the balloon expandable SAPIEN system from Edwards and the self-expandable core valve Evolut system from Medtronic. And the latest design of the SAPIEN 3, the Ultra, the height of the external PET skirt has been increased by 40% in an effort to reduce PVL. The Evolut Pro Plus range of valves has the broadest size range from 23 to 34 mm and now has an external pericardial tissue wrap across all sizes to improve sealing with the annulus. The mechanically expandable Lotus Edge valve, which is fully recapturable and repositionable with high radial strength, has been proposed to offer a theoretical advantage in very heavily calcified anatomy, but this is yet to be definitively demonstrated. While TAVR has revolutionized the management of aortic stenosis, a number of challenges remain, and these are now discussed in turn. Paravalvular leak remains the Achilles heel of TAVR, despite stepwise improvements of transcatheter heart valve design has evolved. Predictive factors for PVL are heavy or asymmetric calcification, valve undersizing, device malpositioning, and incomplete apposition to the native aortic annulus. SAVR has consistently outperformed TAVR for PVL in all trials to date. In PARTNER 2, at 2 years, the incidence of greater or equal to moderate PVL was 8% for the TAVR arm and 0.6% in the SAVR arm, with mild PVL seen in 28.6% after TAVR and 3.5% after SAVR. In PARTNER 3, although there was no difference in the incidence of greater or equal to moderate PVL at 1 year, the proportion of patients with mild PVL remained significantly higher at 29.4% for TAVR versus 2.1% for SAVR. The clinical impact of PVL is dependent on the severity of regurgitation. In patients from PARTNER 2, those with moderate or severe PVL had significantly higher all-cause mortality over the follow-up period of 24 months compared to those with mild or no PVL. On univariable and multivariable analysis, at least moderate PVL was associated with all-cause mortality, cardiovascular mortality, rehospitalization, and aortic valve reintervention. Ongoing debate exists around the significance of mild residual PVL and whether this may impact on long-term outcome, with conflicting study findings. Additional challenges are identifying the severity of PVL post-deployment, optimizing TAVR heart valve result, and stratifying patients for subsequent options such as targeted PVL closure or even valve-in-valve procedures. Stroke is often the most feared complication of TAVR. The majority of strokes are ischemic in etiology and occur in the first 24 hours of the procedure. Predictors of stroke include new onset atrial fibrillation, prior stroke or TIA, balloon post-dilatation, peripheral vascular disease, and aortic atheroma. Major stroke after TAVR is associated with a devastating effect on survival, with an average 30-day mortality more than 3.5-fold higher in patients with stroke. Comparisons of stroke incidence between TAVR and SAVR have been heavily debated. In the high-risk population studied in the PARTNER A and core valve high-risk trials, there was no statistically significant difference in the incidence of stroke between TAVR and SAVR, although TAVR had a numerical excess of strokes in both trials. Similarly, in Partner 2 out to 2-year follow-up, there was no significant difference in the incidence of disabling stroke or any stroke. Unexpectedly, in Partner 3 there were significantly more strokes seen in the SAVR arm, with an incidence of any stroke of 3.1% versus 1.2% at 12 months. The apparently high incidence of stroke after SAVR has been questioned, although it was similar in the Evolute low-risk trial, albeit with no clear difference to TAVR in that study. In addition to clinically detected TIA and stroke, a significant proportion of patients undergoing TAVR sustained cerebral injury from embolic debris. The clinical consequences of this are not well established, and while events are entirely silent, cognitive decline, delirium, and worsening memory function may result. The combination of clinical stroke with some subclinical embolic events has led to the redoubling of efforts to develop devices which protect the brain. Despite the logical benefit of embolic protection devices where filters are placed over the head and neck vessels to catch debris, providing evidence of benefit has been challenging. In the Sentinel study, while there was a trend towards reduced infarct volume, this did not reach statistical significance, and there was no difference in the rate of stroke. Images such as these showing captured debris from Sentinel filters remains compelling, however, and other studies are ongoing, such as the REFLECT US trial evaluating the TriGuard device in patients undergoing TAVR. A meta-analysis of studies of embolic protection devices suggests a benefit from their use, and a definitive trial of embolic protection showing a reduction in clinical stroke would be a major advance for the TAVR field. Balancing the risks of bleeding and thrombosis, both for the peri-procedural period and longer term, is an ongoing challenge for TAVR. On one side, TAVR valve implantation may carry higher risks of thrombosis than surgical valve replacement. Systematic CT analysis of valve function has demonstrated subclinical high attenuation leaflet thickening or halt on 10 to 40% of transcatheter heart valves, and in some cases associated with reduced leaflet motion and clinical sequelae of valve thrombosis. Thrombotic complications are potentially devastating to the patient's quality of life and also linked to adverse valve function. However, on the other side, bleeding complications are associated with adverse long-term outcome and an independent predictor of mortality after TAVR. The popular TAVI trial, which compared the combination of oral anticoagulation plus clopidogrel to oral anticoagulation alone, showed a lower incidence of bleeding in the oral anticoagulation-only arm, without an increased risk of thrombotic complications. Injury to the cardiac conduction system leading to permanent pacemaker implantation remains an important limitation of TAVR. The incidence of pacemaker requirement after TAVR is influenced by valve choice, patient anatomy, and implant technique. Evidence of conduction disease prior to TAVR based on the pre-procedure ECG is the strongest predictor of a post-TAVR pacemaker. The strongest risk factor is the presence of right bundle branch block, and in some studies first-degree AV block, left bundle branch block, and left anterior hemiblock are also associated with an increased risk of high-degree AV block leading to a permanent pacemaker. To an extent, the requirement for pacing is modifiable depending on the procedural technique. Low implantation depth, valve oversizing, larger valves, and balloon valvuloplasty have all been linked to an increased pacemaker requirement. Low implant depth is associated with new left bundle and complete heart block, and a reduction in implant depth across the learning curve for SAPIEN 3 was associated with a reduced requirement for a permanent pacemaker. Implantation of a permanent pacemaker is not itself benign, and is associated with long-term adverse outcome. Not only is there a procedural complication profile including infection, bleeding, hematoma, erosion, and increased length of stay, but pacemaker implantation is associated with increased one-year mortality. Recently, onset of new onset left bundle branch block alone in the absence of high degree AV block, has also been recognised to be associated with increased all-cause mortality, cardiovascular mortality, and rehospitalisation. New approaches and valve designs are required to risk stratify and reduce injury to the cardiac conduction system and reduce the requirement for permanent pacing. Risk models incorporating measurement of the membranous septum in combination with ECG and calcium assessment may provide increased resolution for quantifying the risk of a permanent pacemaker. A modified implantation approach for self-expandable valves has recently been described using the cusp overlap view, which facilitates higher implantation. In parallel, evolving pacing technology, such as the micro-leadless device, may in time reduce the morbidity associated with pacemaker implantation. The durability of transcatheter heart valves remains a key unknown for TAVR and is frequently highlighted as a barrier to extending the indication to younger patients. The durability question has been limited by the lack of consistent criteria for defining structural valve deterioration, the relative importance placed on echocardiographic criteria compared with symptoms or re-intervention, and a lack of side-by-side comparisons between TAVR and SAVR. Long-term follow-up after SAVR is available, and while somewhat variable between valves and patient populations, has set the gold standard for durability. Over 10-year follow-up, freedom from reoperation was 97% and 99.6% for the Hancock 2 and Perimount valves respectively. For TAVR, medium-term follow-up over at least 5 years is now available for increasingly large populations, with reassuring echocardiographic measurements of valve area and valve gradient over time. One potential cautionary note was sounded by an analysis for structural valve deterioration in recipients of the SAPIEN XT valve in Partner 2, who had a significantly higher rate of SVD at 8.8% versus 3.5% for surgical valve recipients, although the comparator SAPIEN 3 valve registry group showed no differences to the surgical arm. Given the continued evolution of transcatheter heart valve devices, with successive iterations prior to the availability of long-term, i.e. 10-year durability data, it is likely that significant transition will occur into younger patients before there is a clear answer regarding valve durability. The combination of unmet clinical need, engineering breakthroughs, and construction of a rigorous evidence base has allowed TAVR to transform the management of aortic stenosis over the last 15 years. Whilst challenges remain, TAVR is continuing to grow rapidly and ultimately will become the treatment of choice for the majority of patients with aortic stenosis. TAVR is increasingly recognised as an appropriate treatment modality for patients with suitable anatomy across the spectrum of risk. In rapidly changing landscape, there are few certainties, but today and over the next 15 years, the role of the heart valve team, comprising cardiologists and surgeons working side by side, looks set to remain the foundation of delivering care to patients with heart valve disease.